Hi everyone. In my paper, Rationality of Ratios, I set out to examine the mandatory minimum nurse-to-patient ratio policies. The nurse-to-patient ratio is the number of patients under one nurse's care. The first law requiring a mandatory minimum nurse-to-patient ratio was passed in California in 1999. Then 5 years later, in 2004, it was implemented. It required every nurse to have 5 patients at the very most. The bottom-up perspective, whereby the hospital administration has free rein over staffing decisions, is the traditional way of staffing, and not surprisingly, is something the hospital administrations are not wanting to change. The newer top-down perspective refers to staffing decisions that would be legislated at the state or federal level that the hospital administrations would have to follow. This is supported primarily by nurses' unions. A few of the major benefits of adopting these minimum ratio laws would be the large number of adverse events that could be avoided if sufficient nursing staff was present, the $5.8 billion avoiding those events could save the hospital, and cutting down on the turnover rate. The largest cost is the $8.5 billion increase in paying the nurses' wages and salaries, and even with the $5.8 billion saved from the adverse events, we're still left with a net cost of $2.7 billion. The price isn't worth the increase in quality to most hospital administrations. In order to help incentivize quality, the Affordable Care Act granted CMS power to control their payments to the hospitals based on quality outcomes. The HRR penalizes hospitals for excessive admissions, or those under 30 days apart. The HACR reduces payments if the patient gets a hospital-acquired infection or other condition not present on admission. The VBP offers monetary incentives to meet goals in quality control. While other states have borrowed parts of the idea, California remains the only state to apply the ratio across all of their hospital units. Massachusetts now requires either a 1-on-1 or a 1-on-2 nurse-to-patient ratio in their ICU. 14 other states have passed regulations addressing the nursing staff problems. 17 other states have introduced similar bills. One study that analyzed outcomes from California, Pennsylvania, and New Jersey said that if California regulations were in place, Pennsylvania would have had 10.6% fewer and New Jersey 13.9% fewer surgical deaths. The Hospital Administration Association's arguments mostly share the following points to refute the minimum ratio policies. First, staffing should be decided based on nurse experience and patient acuity. Second, the ratios are mostly designed for large urban hospitals, which puts an unfair financial burden on smaller rural hospitals. Third, promoting unit cohesion, team building, and effective leadership strategies can improve the workplace satisfaction and help keep turnover rates low. Fourth, local administration can be more sensitive to the community's needs than state or federal legislation. And finally, as I mentioned earlier, the greatest reason is that the ratios will cost the hospitals a very significant amount of money. Most of the nurses' unions argue that state and federal legislation is necessary as local committees are full of retired hospital administrators with conflicting interests. They argue that as it stands now, they are stretched too thin and unable to improve patient outcomes, but if each of them had fewer patients, they would be in a better position to do so. Finally, mandatory minimum ratios give patients transparency and a way to ensure some degree of their own safety because as it stands, they have no way of knowing if they are one of 4 or one of 14 patients their nurse is currently caring for. In conclusion, the mandatory minimum nurse-to-patient ratios have not made much progress in recent years. While most research seems to support the idea that ratios would result in better patient outcomes, hospitals aren't willing to lose that much money. With nurses' unions and hospital administration organizations diametrically opposed and without the federal government stepping forward to subsidize the personnel costs, it seems unlikely hospitals will make these changes in the near future.